Okay, so the first few cases are going to be on stress echoes. So I wanted to tell you a little bit about stress echocardiogram, okay, and what do you see in stress echo. So if you say you do exercise stress echocardiogram, normally what you wanted to see is ischemia. What do you see when you see ischemia in echo? Ischemia meaning, right, I just give you a situation. So someone, for example, have blockage of maybe 50% of their coronary arteries. So at rest, there is no regional wall motion abnormalities because there is no ischemia. So the reason we wanted to do echo is we want to detect that blockage. So we want to induce ischemia. So what happened in patient in stress echocardiogram is when you do stress, if let's say they start with a normal regional wall motion, if they have ischemia, meaning that they are at risk of having ischemia, the regional wall motion will get worse. So whenever you see at start, it is normal, and at stress, it become worse, that is ischemia. Okay? The same goes for, let's say, you start with hypokinesia, and then after you stress, it become more hypo. That is also ischemia. So whenever it's become worse, we consider that it is ischemia, and we normally do stress echocardiogram to look for that. So that is number one. Now, the other one that sometimes can confuse people is what we call as viability or viability testing. You remember that when we do testing to test for ischemia, we actually testing to see people at risk of ischemia. So the regional wall motion is actually normal to begin with. When we do viability, we actually testing to see a region that is already abnormal. So a region that already hypokinetic or akinetic. So what is the reason the echo shows a region is hypokinesia? Is usually three reasons. So number one is whether the place is infarcted. So that's one of the reasons why your echo show hypokinesia or akinesia. Number two, the region is stunned, is stunning. Number three is hibernating. So in these three situations, when you start, you are already hypokinetic. Okay. So in this situation, usually you do dobutamine because you don't dobutamine, you can see the response in low dose and high dose. So the reason you do dobutamine is to differentiate between these three. So what response can show these three? All right. Now, if let's say your patient plays the echo, the wall is already infarcted, that means that it's hypokinetic, right? If you give dobutamine, even when you go to low dose or high dose, there will be no change. So if you start with hypo and you finish also with hypo, that means that that region is infarcted. So that's one. So number two is what we call as hibernating. So you start with hypo. However, when you give low dose dobutamine, that region become better. The contractility become better. However, at high dose, it become worse again. Okay. So what does hibernating mean? So hibernating means like this. So let's say you have a coronary artery disease with blockage of 70%. So what happens is you don't do any revascularization. So you have like chronic ischemia. So the wall or the heart muscle actually reduce their capability or reduce their function to save energy. So that is called hibernating. So that's why when you give dobutamine, so what happens is that at first you increase the flow of blood. So the contracting become better. But when you give high doses, the energy requirement is so much that 70% blockage cannot sustain it. So therefore it becomes worse again. So in patient with hibernating, when you give dobutamine, it becomes better. Then after that, high dose, it becomes worse. So this is hibernating. So hibernating is the best predictor for successful revascularization. So in patient with hibernating wall, that is the best in terms of response to revascularization. The last one is what we call stunning. So example of stunning is this. So let's say someone come with acute ischemia, STEMI or non-STEMI. So when they have acute ischemia, they have hypo, right? Because their function suddenly come down. So let's say you do urgent revascularization. So you do primary PCI. So you open back the vessel, but the muscle takes some time for it to recover back. So if you were to do dobutamine echo at that time, you will see the muscle continue to improve at low dose and high dose. So what does that mean is the muscle is stunned. So you don't need to do revascularization. You only need to wait for the muscle to recover by itself. Okay, so I hope you understand the difference. Whenever we do exercise as echo, we are looking at a region that have at risk of having ischemia. Whenever we do viability, we are looking at a region that is already hypokinetic, and we wanted to differentiate between the three. Is this patient have hibernating, is this patient is infarcted or is this patient having a stunned myocardium? Okay, so I hope you understand that. Then I will show you example of cases here. Okay, now look at this case here. Okay, we just let them play first. Okay, this is our case number 1. So I hope you can see. Okay, let him play first. So this is example of someone with stress echocardiogram. So this is stress. So this is at rest. This is pre-peak. This is peak. Okay, rest, pre-peak, and peak. So look for 5 seconds. Okay, so rest, pre-peak, and peak. Look 5 seconds. Okay. Okay, one more time. So this is another one. This is rest. This is pre-peak. That is peak. Okay, one more time. Rest, pre-peak, and peak. So look at the echo. This is parasternal long axis. Okay, and this is parasternal short axis. Okay, stress, pre-peak, peak. Okay, I give you one more time. Okay, just look. Rest, pre-peak, and peak. Okay. All right. So looking at this exercise stress echocardiogram, what is your diagnosis? A, is it a hibernating LAD segment? Is this an ischemic right coronary artery segment? Is it ischemic left anterior ischemic LAD segment? Or is that multivessel ischemia? All right. So let's go one by one. So let's start with, say, Teisin. What is your diagnosis, Tei?
I think it's a hibernating.
Okay, hibernating. Why do you say it's hibernating?
I think there's an improvement at the LAD territory after the low dose.
And then after that, at high dose, it gets worse again, is it?
Yeah, so the high dose, I can't see very.
Okay, sure. All right. Maybe Sosiling?
Can't really see, but I'll guess it's stunting.
Okay, there is no stunt at the option.
Oh, okay. I don't know. I can't really see the video very clearly.
Okay, fine. Okay, what about others? Sarah, what do you think?
Yeah, it was lagging for me, lah. I can't really see actually.
Oh, I was like, okay, let me show you. I'll show you again. Okay, I'll show you again. Let's go to here only. Okay, all right. Now I just play it again. Okay. Okay, look at all the segment. Okay, look at the apical segment. Look at the. It's actually moving quite well for me. Okay, look one more time. Okay, I just let it play. Okay, that is quite important. Okay, let it play again. Okay, this is rest. This is pre-peak. This is peak. Okay, this is apical. Okay, one more time. Okay, I'll show you one more time. Okay, compare the apical and the apex. Compare to the RCA segment and the RCA segment. So compare, look at the beginning of the apex at rest compared to at stress. Look at this vessel infroseptal at rest. Look at it at stress. Okay, so rest, stress, at rest, stress. Okay, and one more time. Let's look at the parasternal long axis. Look at rest. Look at stress. Okay, look at rest there. Look at stress. Okay, so what do you think? Anyone want to change their answer?
Ischemia in the lateral
Okay.
wall.
So ischemia, which segment? Just tell me in terms of coronary.
RCA.
Okay, very good. RCA segment. So what do you say is ischemic RCA segment?
Because at rest, the contraction looks good
Okay.
overall.
Okay.
But then at low dose, big dose.
This is not dobutamine. This is exercise.
Oh, sorry. Exercise. With gradual increase of exercise, looks like there is
Worsening, right?
Worsening.
Okay, so you are correct. So the answer actually, if you look properly, this is actually multivessel ischemia. There is actually two. There is worsening of the LAD and worsening of the RCA. Okay, I will prove to you. Okay, so this is important. I will prove to you. Okay, I show you the next gambar here. All right. So just wanted to tell you. Okay, when we do stress echocardiogram, if we start with normal regional wall motion, if it's become hypokinetic on exercise, then it is ischemia. So in our stress echo, in the beginning, there is no regional wall motion abnormality, but at exercise, there is obvious regional wall motion abnormality at the LID, RCA, and silk territory. So this is multi-vessel ischemia. I will show you later. Okay, look at this, okay? So look at this. Okay, now I actually will put you some markers. So just look inside the kotak there. Okay, just look inside the kotak and just compare, okay? Now compare the apical, that one side of the apical and the apical. Do you think that is worsening or not, the apex? Yep, you can see, right? That's at the beginning. That at stress, you can see that the apex is worsening, right?
Yep.
Yes.
So what I suggest to you when you do an echo, stress echo, so what actually you do is you try to put your hand on top of the other coronary region. So this is actually an LAD region, and you can see that there is actually hypokinesia. All right. Now I show you one more. This is basal infroseptal. So this is RCA region. Okay, this is at rest. This is at stress. Now look at that region. You see the worsening or not?
Yeah, the thickening is lesser.
Yes, the thickening is right. So you see that there is actually the most obvious one is ischemia at the LAD and RCA territory. So this is a multi-vessel disease. So what do you think? Ceiling, can you see?
Yeah.
Yeah, you can see, right? Okay. After I do that, all right. So this is also the same. So you have to remember when you do parasternal log axis. So this is the LAD segment there. Okay. All right, and this like this one, this on the top is this is the RCA or circumflex. Okay, here is RCA or circumflex. Now you just look at the parasternal log axis. Okay, don't look at short axis. Look at parasternal log axis. Look at that, the difference between that and that, especially at the mid apical septal there. So you can see there is actually worsening. Okay, just look again. Look at the basal infra one. Can you see the worsening from at rest and to stress? Can you see that? Facing
Can.
can right. So RCA territory and LAD territory is worsening. So this is a multi-vessel ischemia, right? So all of you agree? Sarah, are you okay?
Yes, yes.
All right. Now look at this. This is another echocardiogram. Okay, this is a short axis view of the echo. Okay, so this is at rest. Okay, so this is rest. This is low dose. This is high dose. This is dobutamine stress. This is rest. This is low dose, and this is high dose. Okay, so just look at properly. Rest, low dose, and high dose. Okay, rest, low dose, high dose. Rest, low dose, high dose. Okay, so do you want to see again, or are you okay? All right. So what is your diagnosis from this dobutamine echo? RCA ischemia, LAD ischemia, LAD stun, RCA hibernating.
CA ischemia.
Okay, RCA ischemia. Someone? Ceiling?
Looks like it's improving with
I think it's yeah, I also think it's improving.
Okay,
I wouldn't
so
say it's ischemia.
so what do you say?
I would say it's RCA hibernating.
Okay, RCA hibernating. All right, anyone else? Sarah?
I thought it was RCA ischemia.
Okay, RCA ischemia. All right, so let's see what's the answer. So the answer is LAD ischemia. Okay.
Okay.
So the patient begin the test by having a normal regional wall motion. So this is not a viability test. Okay, a viability test is testing something that is beginning with regional wall motion abnormality. However, there is normal motion of the LAD territory that's worsened with exercise. So this is an example of LAD ischemia. So I just show you example. So look at that part. Okay. So that's what happened. Okay. So just at the LAD segment, so this is LAD normal. You can see that the LAD there, if let's say I move a little bit the kotak here, you can see that this LAD region is becoming more hypokinetic. So this region here from here is better. This region from here and here is good. Okay, but this region has become hypokinetic. This LAD territory here. Maybe the rectangle is not so good, but it start. You can just look at the thickening. It start with a normal thickening. but the thickening become worse here at the LAD segment. Okay. However, this is at the RCA segment is actually normal. So this is normal. This is also normal. Okay, if you look at the thickening RCA segment, it's okay. You just look at the LAD. So the LAD thickening start coming down. So this is also LAD ischemia. So this is an example of, this is not dobutamine, this is also exercise stress echocardiogram. All right, so let's see this one as well. Right, so look at that. Right, so look at that. So this is LAD at the beginning. So that's LAD territory. Okay, that's LAD there. Look at LAD there. You see that? Yeah. So this is normal. Look at that. The mid segment especially has become hypokinetic. Okay. It start with normal. Now it become hypokinetic. Right. So this is an example of LAD ischemia in exercise stress echocardiogram. So usually when we diagnose ischemia, then there is a benefit of revascularization. Okay. So this is actually dobutamine stress echo. Okay, this is a short axis view. Okay, I already done number dah. So this is rest, this is low dose, this is high dose, and that is high dose. Okay, so usually less than 10 is low dose, 10 to 40 is high dose. Okay, so rest, low dose, high dose. Okay, just one ja, rest, low dose, high dose. Last one more time. You just concentrate on the LAD segment. Okay, concentrate on the LAD segment. Rest, low dose, high dose. Right? Okay, look at the short axis of DSE above. What is your diagnosis? LAD ischemia, LAD hibernating, LAD stun, or infarcted LAD? Jeremy?
Ischemia already.
Okay, Ate? Sili?
Hibernating.
Which part is hibernating?
Boss can see one more time.
Can? Okay, I show you again. Okay. Right, I show you again. Okay, this one.
Oh, boss, infarcted. I think it's infarcted.
Okay, infarcted. Okay, look at this apical segment. Look at what happened from apical segment here to apical segment there. Okay, look at this apical segment. So what happened from rest to low dose? Look at that. What happened from rest to low dose? Look at what happened from low dose to high dose.
Hibernating.
So
Yeah.
rest, low dose to high dose. Okay.
Hibernating already.
Okay. So what is your answer?
B, boy.
Boy. Okay. So everyone agree that it's hibernating LAD?
Yeah.
All right. So this is hibernating left atrial descending artery. You are correct. So Celine, do you think this will be benefit from revascularization?
Yes.
Okay. So of all the changes in echocardiogram, the one that have highest positive predictive value for positive response after revascularization is hibernating or hibernating segment. So I just remind you again, in ischemia, you are at risk of having ischemia, meaning that you have blockage, but blockage haven't caused ischemia at rest. It only causes ischemia at stress. In hibernating, you actually having chronic ischemia. So the wall is actually conserving energy. That's why there is hypokinetic there. So if you were to revascularize, the wall will improve from hypokinetic and become better. In stun, you don't need to do anything. In stun is basically someone that has already have pattern vessel, but it is taking time for the heart to come back to normal. So, patient with infarcted LAD, do you want to revascularize the patient?
No, it's not going to help
It's not.
unless it's anything or
Yeah, correct. So if it's infarcted, by definition, it's not going to change. So how do you see infarcted from echo? It starts with hypokinesia, it finishes also with hypo. So that is infarcted. Or you start with akinetic, it finishes also with akinetic. That is infarcted. Okay. So let's see one more case. So few important things to stress on echo. Okay. If you are doing a stress echo, mostly you are looking for ischemia, namely worsening in regional wall motion. If you do dobutamine stress echo, of course, you can still look at ischemia, okay? Because if they say there is a worsening of wall motion, you know that it is ischemia. However, the most important utility is the region with existing RWMA. So this is the one, okay? If you have hypo at start, it become worse some more, it is ischemia. Okay, so maybe we try to ask this to Saravanan. Saravanan, can you explain or not the first sentence? You start with hypokinesia, and then you become worse with dobutamine. So what is your explanation for that? What is happening at the muscle?
If it is hypo, then become worse.
Yes.
It is infarcted.
Okay, so what is happening at the area that is hypokinetic on your wall? You say that it is infarcted. So where does the ischemic come from?
Oh yeah, ischemia. Sorry.
So it is ischemia. So can you tell me what is happening at the wall or not? Because this is important to understand the concept.
The wall, there is a worsening of original wall,
Okay.
right?
Okay, there is a worsening of the wall. So you say that it is ischemia, right? Okay. So at the start is only ischemia that is happening, you think?
Sorry, I don't get what you asked.
Okay.
What you
Now,
asked?
let's say someone let's say people wanted to ask you in plain language so that you really understand what are you doing actually. Okay. So let's say like student ask you. Okay. So Dr. Saravanan, okay, you say that it start with hypo. If it's become worse, it is ischemia. So what does it mean on the wall itself?
Lack of blood supply.
Okay, lack of blood supply, right? Tasting, you want to try? Celine?
Don't know.
All right. So you see, okay, if you have hypo at start and there is no changes with dobutamine, that is infarcted. Okay. If you start with hypo, it is better at low and high dose. It is stunning or it is non-ischemic cardiomyopathy. If you start with hypo, it is better at low dose and worse again at high dose. That is hibernating. You know what is this first one mean or not? So what that first one means is that in that region of the wall, right, you already have an infarcted muscle. Yes, but you also have a region of peri-infarct ischemia. So you start with infarcted plus peri-infarct ischemia. Therefore, when you give dobutamine, it becomes worse. If you, let's say, in this situation, you don't do anything, there is a chance that it might get worse if the region that is at the peri-infarct zone becomes worse. So this is someone with infarcted already. That's why you have hypokinesia to begin with. However, surrounding region of the infarction, you also have ischemia. So that's why you start with hypo. So you have infarcted with peri-infarct ischemia that become worse with dobutamine. Is that okay? Is that clear?
Yeah.
Now let's see another case. Okay. So this is case number 3. Okay, I already put you. So this is the case just now. Okay. This is start. This is at low dose, so it become better. So start with hypo, low dose become better. And this is high dose. It become worse again. So this is hibernating LAD. Okay. So this is case number 4. So this is a parasternal long axis view. You just look at the parasternal long axis view here. Okay. You look at parasternal long axis view. Okay. Look at the other one. Okay, look at this. So this is apical 4-chamber view. Right. This is apical 4-chamber view. One more time, we go back to the beginning. So this is parasternal long axis view. So look at the LAD segment. Oh my God. Can you all hear me?
Can hear you, boss.
Yeah.
Video running
Just that
smooth.
the video only start, I think.
Is the video running smooth there?
Oh, it's actually stuck. So just give me a moment.
But your voice is clear.
All right, it's okay. I just share one more time. Just give me a moment. So what happened is that so that's number 4. All right. So let's share screen. Can you see the screen now?
Yep.
Okay, so look at this one. Look at this number 4. Okay, so look at this, right? So now look at the LAD segment at the beginning. So this is rest, this is low dose, okay, and this is high dose. Rest, low dose, high dose dobutamine. Okay, just let it move. Rest, low dose, high dose. Okay, now let's go another one. Okay, rest, low dose, high dose. Okay, rest, low dose, high dose. Right? So look at the short axis of the dobutamine stress echo. What is your diagnosis? A is LAD ischemia, B is hibernating right coronary artery, C is stunned LAD, and D is infarcted LAD.
E, stun already.
Stunned LAD, okay. Take
Yeah.
stunned LAD also. Celine?
Yeah, stun LED.
All right, let's see the answer.
No?
Aiyo. Aiyo.
Okay, let's see one more time. Okay, let's see one more time. Okay, see whether I can whether you can see or not. Okay, so this is number 4. So I do like this. So look at that. Okay, hypo. Correct or not? Do you agree that the basal infralateral is hypo?
Yeah.
Okay, look what happened there. Do you agree that from hypo has become better? Look,
Yeah.
what do you think? From here to here, has it become better or not? Okay. And then it become worse back there. Okay, so if you're not convinced, let's see this one. Okay, I'm sorry because this video is not clear because the cases is difficult to find. Okay, so look at that. That is basal infraceptor. Okay, what do you think from here to here? Okay, look at that. Look at the thickening. Does it become hard? Does it become better?
Better.
Okay, what now has it become what now?
Worse.
What's back? Okay, so let's see back at the from the previous one. Okay, okay. Now look at this. Okay, from here, from here, from here. Okay, so what is happening here? So from it, now it is worse. It's better now. It become worse again. Okay, rest, low dose, high dose. Okay, now okay, look at this.
Can I ask what is the fourth image? I thought the fourth image, the
Oh, the
apical
fourth,
region.
the fourth is recovery.
Oh, okay, okay.
Okay,
Right.
so this is rest, low dose, and high dose. So normal, better, get worse again. So this is actually hibernating RCA segment. Okay. So but even though you cannot get it, maybe from the picture it is unclear, but do you understand the concept or not? Let's say you see echo that is clearer.
Mm.
Understand the concept, okay? So if let's say you do stress echo, you are looking for hypokinesia, you're looking at ischemia. If you're looking at dobutamine, it's viability. So the region is already hypokinetic, okay? So maybe I just ask one by one. Okay, Jeremy, let's say you do a region that is hypokinesia, you do dobutamine stress echo, at 5 microgram, it is still hypo, at 10 it's still hypo, at 20 it's still hypo. What is your diagnosis?
He's infected.
Okay. Pacing, let's say you start with hypokinesia, at low dose it become better, at high dose it also become better. Take stunning, very good. Ceiling, let's say you start at hypo, at low dose it become better, at high dose it become worse.
Hibernating.
Okay. Let's say Saravanan, at starting it is hypokinesia, when you go to high dose it become akinetic. What is it?
Become akinetic, in fact.
We start with hypokinetic. Okay, when you give dobutamine, it becomes akinetic. What is it?
Ischemia.
Very, very good. So it is ischemia, but it is ischemia surrounding an infarcted segment. You understand, correct? Why is it infarcted? Because at the beginning you already got the regional wall motion abnormalities, right? Because you know that if they say at the beginning that region is only at risk of ischemia, it is not ischemia yet. The regional wall motion should be normal, but you already start with hypokinesia, meaning that something is strong happening there. So you start with hypo. When you do echo, it becomes akinetic, so it becomes worse. So meaning that there is a region that is infarcted. There is also a region at risk around that infarcted segment. So you need to revascularize the patient. Otherwise, if you don't revascularize, it becomes worse. Then it becomes akinetic permanently. Is it clear?
Yeah.
Okay, good.
How many, like out of 17 segments, right? How many segments that you have to have for you to say it's non-viable certain territory? Do you calculate?
One segment is enough.
One enough.
One is
To
enough.
say
Yes.
it's non-viable.
Yes, to say it's non-viable.
Right.
Okay, one segment is enough. So if you choose one segment, it becomes more sensitive. If you do two segments and above, it becomes more specific. So the more segment you choose, the more specific your test. The less segment it is, the less the more sensitive your test is.
All right.
Okay, so this is number 5. Okay, let's see this one. So I go show you. This is at rest. This is low dose. This is high dose. This is recovery. Rest, low dose, high dose, recovery. Okay, dobutamine stress echo. Less, low dose, high dose, recovery. All right. One more. What is the most likely diagnosis of stress echo? RCA ischemia, infarcted RCA, hibernating RCA, or stunned RCA?
Key, donkey.
Sorry? Stunned RCA. Who's answering stunned RCA?
Me, boss. Jeremy.
Okay. Some more? Sarah?
Yeah, I probably will think stun RCA juga, because I think it improved. Yeah.
All right. I should always forgot Precious because no video. Precious, what do you think?
I think stunned RCA.
Very good. Stunned RCA. So ceiling?
Same thing.
Same. Okay. So I think all of you are very good. So this stunned RCA. Okay. So actually, like finally number 5, you all got answer correct. So inferior, getting better, and much better. All right. So this is a stunned RCA segment. So do you need to revascularize or not, Precious? Huh?
You just have to wait, or
Yes.
Yeah.
Very good. You just in this kind of case, you just need to wait. All right. All right. So that's all on stress echocardiogram. So does it make clear a little bit the stress and dobutamine stress echo?
Yeah.
Does it make clear a little bit? Okay. All right. So we are finished with that. So this is another feature. So this is actually just the apical long axis view of an echocardiogram of someone. Okay. So this is the left ventricle here. This is the left atrium here. All right. All right. So this is the color Doppler across that left ventricle. So that is left ventricle. That's the left atrium. That's the color Doppler across that. Okay. So this is when I put the continuous wave Doppler, I see this thing. Okay. When I put the continuous wave Doppler, I see this thing. Okay. Now just look again at the color. Look again at the color. Okay. And also look at the Doppler. Okay. All right. So a patient have the echo and Doppler action previously. What is your diagnosis and why? Oops. Ada bagi answer dah. Did you all see? Alright, so what do you think is the answer? Saravanan. What does this video show?
Mitral regurgitation.
Okay, mitral regurgitation. Okay. Sama, what is your diagnosis you think here apart from the mitral regurgitation?
Aortic regurgitation.
Okay, I'm sure you already seen the jawapan just now. Okay, so Siling, why do you say this is aortic regurgitation?
I think because there is backflow into the LA due to the high
what?
pressure.
High pressure where?
Diastolic MR.
Very good. So both Siling and Saravanan is correct. There is a diastolic mitral regurgitation. Okay. So Jeremy, can you see the diastolic MR?
Okay.
So you look during systole there is one MR. So one MR during diastole there's another MR. So systole, that's 1 MR. During diastole, you look at the Doppler flow here. So this is the flow during diastole. So this is flow during systole. So this is the normal MR during systole. This is the MR during diastole. You see that? So whenever you see MR during diastole, you see that? So that is a diastolic mitral regurgitation. So what happened is, this patient have severe IT regurgitation. The LVEDP is so high, so that at end diastole, the pressure inside the left ventricle is higher than the pressure inside the left atrium. So you have the diastolic mitral regurgitation here. So let's see, let me show you. So that is MR, diastolic MR, MR, diastolic. So when it's systole, it is MR. When it's diastole, you have a diastolic MR. So are all clear with this?
Yep.
Okay, so this patient have diastolic MR. Precious, what do you think about the patient? Is the patient stable or not stable, Precious?
Patient is what?
Do you think
Unstable.
the patient is stable or unstable?
Unstable having the increased LVEDP.
Okay, so one is the reason you say is patient is having increased LVDP. Another, can you tell me another reason that you can think from the Doppler that you might say that the patient is unstable? So what do you think, Teisin? Is there anything at the Doppler parameter that suggests the patient is unstable? Anyone?
They call the, what sign is it? The hill picky or whatever.
Hilpiki.
Bukan yang
Itu bukan mitral prolapse ke? Yang Pickel-Hauby sign.
Is it because the velocity across the
Yes. What do you say?
valve is more than 4 centimeter, more than 4 meter per second?
Okay, I want to ask you, okay? This pressure here, right? So this is MR pressure. This is pressure between which chamber and which chamber?
LALV.
So between LALV ke LVLA?
LVLA.
Okay, LVLA, right? Usually your MR, the velocity is 400, lower than 400 or higher than 400?
Lower.
Are you sure? Okay.
Higher.
It normally should be higher, okay? You know that, okay. So what is the difference in pressure between the LV and LA?
Different in pressure. So you got to minus the
So
diastolic and the
about
systolic.
80.
No, LV systolic. So this you already got, right? So this is the difference between LV systolic and LA pressure. So what's the difference? So what is the gradient between LV and LA during systolic?
64.
Okay, so the difference in the gradient is only 64 millimeter mercury. Okay. Now let's say what is the normal left atrial pressure?
10 to 15.
Okay, let's say you take is high, let's say 15. Okay, so what is the LV systolic pressure if let's say your LA pressure is 15? So Sarah said LV systolic minus LA pressure is 64 millimeter mercury. Correct or not, Sarah?
Yeah.
Okay, so what is the LV systolic pressure? Is the LA pressure is 15.
64
40,
plus
Okay,
64 plus 15.
Yeah.
Okay, 64 plus 15 is how much?
80.
79.
Okay, 79. Okay, so if your LV systolic pressure is 79, what is your aortic systolic pressure if there is no aortic stenosis?
79.
Okay, so if let's say aortic systolic pressure is 79, what is your blood pressure?
Systole will
There's
be
a
lower.
profession.
No, what is your, if let's say your LV systolic pressure is 79, what is your systolic blood pressure in the absence of aortic stenosis?
79.
Also 79, right? So the patient is stable or not? If they say the systolic blood pressure is 79. No, right? Okay. So just by looking at the MR jet here, you know that the patient is not stable because the MR jet usually is between 6 normally, 5.5, 6. This is 4, meaning that the LV systolic pressure is very low. So if LV systolic pressure is very low, that is meaning that aortic systolic pressure is low. So this patient is unstable. The systolic blood pressure is only about 80 millimeter mercury. Is it clear?
Yep.
Okay. Sarah, clear, Sarah?
Yes.
Okay. Jeremy, is it clear?
Sorry, boss. The 65, you got it from the image is it, the color Doppler?
You see this systolic Doppler, right? The peak velocity is
65 is
4,
there, is it?
4 meter per second. You see that 400?
Uh-huh.
That is 4 meter per second. So you know that LV systolic pressure minus LA pressure is 4V squared. So 4, the V is 4 meter squared, 4 times 4 squared. So 4 times 4 squared is 16, 16 times 4 is 64. So the LV systolic pressure minus LA pressure is 64 millimeter mercury. Clear or not?
This is one of the question in the exam.
So do you understand now, Jeremy? You want me to explain some more?
I understand.
Okay, all right, good. So this is acute severe atrial fibrillation in shock. The reason is there is diastolic MR. That means that the LVEDP is very high. Looking at the peak velocity of that diastolic MR show that during diastole there is time when LV pressure is higher than LA pressure. Then the forward flow through mitral valve is slow. So the peak MR gap is only 4 meters per second. That means that the difference between LV systolic and LA pressure is only 64, which means that the blood pressure, the systolic blood pressure is low. So the other causes of diastolic mitral regurgitation, apart from acute severe AR, this one you just remember. If we have severe first degree block or high grade AV block, if we have premature ventricular complex, if we have constrictive pericarditis, okay, but this diastolic MR, the velocity is quite high. The rest is only got a little bit. This one cause high. So only severe acute AR cause high velocity diastolic mitral regurgitation. All right, look at this echo. All right, so maybe Ceiling, you want to answer? Give spot diagnosis.
Wait. Something wrong with the AMVL.
Okay. All right, this is open to all of you. Okay, spot diagnosis. Precious.
Aortic regurgitation dissection, is it? Or dilatation?
Okay, so good. One is it? One of it is aortic dilatation. Good. Okay, what is the other diagnosis?
That
I think
Bicuspid aortic valve.
Okay, Sarah, Vadan, how do you know that this is bicuspid aortic valve?
It's a doming of that valve, is it?
Very good. One, there is a possible doming. Okay, there is one other reason that I'm looking at. So the correct answer is bicuspid aortic valve and aortic dilatation. How do I know that this is bicuspid aortic valve, Sarah?
That is a doming of that. I mean,
Okay,
the RCC.
that is one. Okay, but what is the other one? Precious, want to try?
The other valve,
Hmm.
C.
Hmm.
You can confirm with the Doppler, right?
Okay, so why do you think that this is bicuspid aortic valve? Okay, guys, look at where the aortic valve close. Right, the
Yeah.
aortic valve close is very eccentric, right? A normal aortic valve should close in the middle. Okay, whenever you have eccentric closure, you look at the closure line. The closure line is actually very eccentric, or the side. Okay, at that side. Okay, not here, not at the middle. Okay, is it clear, Saravana?
Yes, yes.
Okay, so this is actually bicuspid eccentric closure line with that. So this is bicuspid aortic valve and aortic root aneurysm. Okay. All right. So this is another question. So this is a parasternal long axis view, parasternal short axis view. Okay. So Ceiling, comment on the echocardiogram. Is there any regional wall motion abnormality or not?
the RCA region.
Okay, your RCA region. So do you mean the region that is shown by the arrow?
Yeah.
Okay. So what do you think? What do you think, Saravana?
Hypokinesia in the inferolateral wall.
So you think it's the same place here, sir, or the other side? This one? Or this one?
The second one here.
This one. This one.
Yes.
Okay. So what do you think, Jeremy? Same also?
Just some mild hypokinesia there.
All right. So basically, what you see is, okay, I want to ask you a question, right? You just, okay, let's say you just look at the thickening, okay? Ignore the motion, just look at the thickening. What do you think about the thickening of this side compared to other side?
Less.
Is it less or normal?
Less.
Okay. Okay, so this is actually something that is special, okay? This is something that can confuse you all. So for example, you might say that this inferior wall have regional wall motion abnormalities. So this is actually a typical presentation of someone with high, let's say your patient got ascites, right? So whenever your patient got ascites during diastole, okay, this lever, okay, will push the wall of the left ventricle inside. So whenever it's doing diastole, it seems as if this is pushing this towards this side, right? So this is not hypokinesia, this is just a pseudo dyskinesia of the inferior wall due to someone that have abdominal pathology. Okay, this is what we call pseudo dyskinesis. So this is a rare condition for someone that have like very high intra-abdominal pressure. The trick is to just look at the thickening, don't look at the motion, because you know that during diastole, this is actually pushing towards that side, right? This is a pseudo dyskinesia of maybe this is about infroseptal wall. So this is pseudo dyskinesis. So pressure from abdominal content flatten the inferior wall in diastole. So in systole, the cavity become rounder. In diastole, it's become flatter because the abdominal pressure is actually pushing towards the wall of the heart. Okay, the diastolic flow reversal in the descending aorta cannot be explained by left arm AV fistula, severe aortic coarctation, stiff vasculature due to aging or hypertension, moderate aortic regurgitation. I'm not sure whether there's anyone answer some or not. Okay, so choose. Silik, what is your answer?
C.
Okay, Steve. All right. What about you, Saravana? So this is diastolic. So all of this can cause diastolic flow reversal except what?
D.
So D
Moderate
cannot.
AR.
Okay, D cannot cause diastolic flow reversal. Okay, Jeremy.
D, donkey.
Donkey. Okay. Patient. Which one cannot cause diastolic flow reversal? B, aortic coarctation. Okay. So the answer. Okay, Bera. So the answer is.
Oh,
Okay, you want to change your answer? Okay, let's go one by one. Okay, what happens if you have left arm AV fistula? So in AV fistula, you actually have continuous flow in systole and diastole. So you have to and fro flow. So if let's say you have left arm AV fistula, so what happens is you can have flow reversal at the left subclavian artery that go to the aorta, and then you can get flow reversal. Now, a patient that is old, because the vasculature is stiff, even if they have moderate aortic regurgitation, you can also see diastolic flow reversal. So diastolic flow reversal not necessarily a marker of severe aortic regurgitation. So what is the answer? So the answer is aortic coarctation. Okay, coarctation. Okay, coarctation, there is no flow reversal. Okay, there is only forward flow. Okay, now the CW envelope is explained by, all right, A, movement of the transducer out of jack, B, respiratory variation, C, transient increase in LV pressure, D, transient decrease in LV pressure. Okay, so what is the cause of this Doppler tracing here? This Doppler tracing is across the aortic valve. So this is the apical 5-chamber view. Doppler is between the aorta and the left ventricle. What's your answer and explain? Precious.
Transient increase in LV pressure.
Okay, why do you have that transient increase in LV pressure? So why you just C? Okay, the correct answer is C. Good. What is the reason you choose the answer C?
The PVC that caused that.
Very good. Okay, so you see this patient. This patient have aortic regurgitation. So this is the aortic regurgitation here. All right. So however, in the middle of the cardiac cycle, the patient developed PVC. So when the patient develop PVC, there is transient increase in LV pressure. So when there is transient increase in the LV pressure, there is slight reduction in the blood that is flow from the aorta back to the left ventricle. That's why the flow of the aortic regurgitation here, you can see this notching here. So this notching here is because of transient increase in LV pressure because of premature ventricular complex in patient with aortic regurgitation. So everyone understand that?
Yeah.
Yep. All right. All right. So this is the question. Okay. This is a 63 years old female with the EKG below. All right. The patient have normal chest X-ray. Okay. The patient have normal chest X-ray. Suddenly develop hypoxia. What is the most likely cause of hypoxia? Right. So maybe Saravanan, you want to try?
Then hypoxia.
What is the most likely cause? So the patient have myocardial infarction, correct? So the patient got MI. So the MI is inferior.
Inferior.
Okay. Then the right-sided is also up. So inferior and also right-sided MI. Correct or not?
Yeah.
Correct. So what is the reason the patient suddenly developed hypoxia in the presence of normal chest X-ray?
B, mitral papillary rupture, which is a bit rare for inferior MI.
Okay. But the chest X-ray is normal?
Oh, chest X-ray is normal. That means PE, is it?
Okay. That is one of the possible reasons is pulmonary embolism, but it's very unlucky, right, to get pulmonary embolism and RV myocardial infarction at the same time.
But how the hand? Cyanosis, this one?
Okay, why suddenly the patient need to develop methemoglobinemia all of a sudden?
Nitrates can cause that.
Okay, fine, right? Okay, maybe that is possible. Okay, so Ceiling, what do you think the answer? I already give the answer, right? Ceiling. So this patient has inferior MI with right-sided involvement. Okay, so she suddenly developed hypoxia. Okay, but the chest X-ray is normal. So what is your most likely answer for this patient?
Shunting. I don't know.
Okay,
I don't know.
so this is actually a very interesting cases. It is quite rare, but it does happen. Okay, so if let's say you have inferior MI and right ventricular MI, what happened to the pressure inside the right ventricle? Ceiling.
Hi.
Okay, if let's say your pressure is high inside the right ventricle, usually PFO, right? If you have left pressure is higher than the right pressure, what happened to the PFO?
Reverse.
PFO will go from left to, PFO will be close lah.
If let's say from left to right, it will be close, right? So what happens if you have sudden increase in the right heart pressure?
Then there will be flow from the right to the left.
Yes. So, for example, someone that have PFO, let's say the PFO is not present during normal because the LA pressure is higher than the right side pressure. Let's say they suddenly develop right-sided MI, RV myocardial infarction. The RV pressure suddenly go up. They can have sudden reversal of flow from right to left, and they can cause hypoxia suddenly. Okay. Have you ever seen this before?
No.
Okay. So I show you these cases. Okay. So this is that patient, this is the patient transesophageal. So this is which chamber is this, Ceiling?
I don't know.
Left ventricle or right ventricle?
I don't know.
Okay, what is this? Semua don't know. What is this?
I don't remember TEE.
What is this on the one that the mouse? That's left atrial appendage, okay? If that is left atrial appendage, what is this, Ceiling? Left ventricle or right ventricle?
Left.
Okay, what do you think about the contractility of the left ventricle?
Again, looks okay.
Okay, right? Looks normal, right? Jeremy, are you agree that the LV looks normal, Jeremy? Okay, so the left ventricle looks normal, okay? Right. All right, so this is mid-esophageal view of the transesophageal echocardiogram. So this is the left atrium. That is the right atrium there. This is tricuspid valve. That is right ventricular outflow tract. Okay, so that is the pulmonary valve. Okay, now Saravanan, what is happening with the right ventricle here?
Dilated.
So the right ventricle has become dilated. Okay, good. So Jeremy, what is this structure here?
The
one
PFO,
that, yeah, this is, so what is the structure that I am rounding here? That is the interatrial septum, right?
yeah, it's moving in towards the left side.
So the interatrial septum is actually moving towards the left atrium, right? Okay, so this is a patient that have developed RVMI. You can see that the RV is dilated. the pressure inside the RV is high, the pressure inside the RA is high. So if you have PFO, what will happen, Precious?
Right side, right to left shunt.
So you can have right atrium to left atrial shunt. So how do you want to prove that?
You can TEE. You can see the pattern formula. You do contrast.
Okay, you can do contrast. Okay, what is the most simple way to do it?
Valsalva.
Valsalva, very good. Okay, but Valsalva you cannot really say anything. Just easy, you put color.
Bubble test.
No need. This one got color straight away. See the color flow? Nampak tak the color flow from the right atrium to the left atrium? Can you see that? Can, right?
Yeah.
Color go through the pattern foramen aorta to the left atrium. Okay. Now, so what happened in this patient is she's okay, but because she developed right ventricular MI, the right atrial pressure suddenly go up and open this PFO, and they even do a bubble study. Look at this bubble study. In this patient, they don't even need to do Valsalva, meaning the right atrial pressure is very high. Look at the bubble study. You can see a lot of bubble on the left side, right? Can you all see the bubble on the left side? This is left atrium. This is right atrium. Left atrium. Can you see the bubble going to the left side? Okay. Now, bubble study show big right to left shunt from the pattern foramen ovale. Okay. Right. So this is, they do bubble study again. What has happened? Saravanan, is there any more right to left shunt or not, Sarah?
No.
No. So what has happened?
The pressure has reduced.
Okay. Because of what?
The ischemia has improved. Maybe we
Okay.
thrombolize.
Okay, maybe they thrombolize. Okay, very good. That's one good answer. Silly?
It's revascularized.
Okay, revascularization. Okay, RK is it? Precious?
Pressure on the LV you already improve after.
Okay, so this is amazing case. Okay, this is amazing case. This is case in Mayo Clinic. So when you know it's the case in Mayo Clinic, you know what are they doing, right? So basically, they put an RVAC. Okay, right ventricular assist device, RVAC. So it's amazing case. It's a very rare case, but it happens. So let's say next time you see someone that has sudden hypoxia, literally the oxygen come down to 80+%. So this patient has RVMI, the RV pressure go up, open the PFO. So what they do is they put in an RVAC, the RV pressure come down, and don't no longer right to left shunt after this. So they don't even need to do any surgery rather than putting the RVAC. The RVAC is percutaneous RVAC, so they don't do any surgery. All right. Okay. Interesting case, right?
Yeah.
Can I ask? I mean, usually when we have an MI, right, we don't really subject them for theory. But what prompt this patient to be?
You see, the people here straight away know that this is high on their index of suspicion because the chest X-ray is normal and the patient develop hypoxia and they cannot explain. Like, you know, it's very rare, right, for someone, unless they are in distress, for the oxygen to be 80+% for no reason, especially after MI, right? Unless they are collapsing or what. So this patient is not collapsing, but she's hypoxic, so they don't know what's the reason.
The patient was intubated, then subsequently had a thing done.
Yes, correct.
Okay, all right, cool, very nice.
Right. So this case, all right. So maybe Precious, what you can see, this is transesophageal echo. So that's the left ventricle, right ventricle, left atrium, and right atrium. Okay, what do you see here, Precious?
So the left atrium you have. What's that? You have color flow.
Okay.
But which one is to the LV?
Okay, so there is a color flow through the LV. So what is the thing that worry you right now? You have a flow conversion going from LA to LV. So what's your worry right now?
Is it
So what can cause color flow like this?
stenosis?
So yes, mitral stenosis can cause color flow like this, correct? Okay, so mitral stenosis. So I show you one more picture. Okay, they flow process across the mitral valve. Right. So this also I wanted to show you. Sometimes people say that you cannot do PISA for MS. You can do. You can see there's nice PISA there. You can actually do same PISA for MR for MS. Okay. Right. Now look at the echo here. Okay. So Ceiling, what is the cause of the mitral stenosis? So that's mitral valve.
Skin.
So that's the mitral valve there. So what is the cause of mitral stenosis?
Is it thickened?
So is it rheumatic or degenerative?
It looks thickened at the from the tip to the base.
Okay. So this is rheumatic or degenerative MS?
Degenerative.
Salah. Precious?
Do the parachute.
Diastolic bone.
So, okay, it's not parachute, salah. Precious, what's the diagnosis?
Rheumatic.
Rheumatic also salah. So you have flow.
There is a connection between LV and RV.
Oh, tidak. So, okay, this is what I want to give you. Whenever you see a hole there, right? Okay, be suspicious. Okay, in transesophageal four-chamber view, you often see a hole there. That is not a hole. That's just an artifact. Unless you can show a flow, color flow inside there. That is normal. That is not a hole. That is just an artifact. Okay. So what happened is this is actually one of the unusual case of the mitral stenosis. Okay, but you can see this and definitely can come out in exam. Okay. Right, so I go a little bit nearer to the mitral valve. What is your answer?
Ossification.
No? Okay, one more time. I already show you there, the garis there.
And the let me see.
Okay, so you see this line here from here to here, this small line there. Okay, one more time. You see this line there, from there to there. You see that line there? This very tiny line. Okay, so
mitral membrane.
So this patient actually having supramitral membrane. Okay, supramitral membrane. So that is the one that is caused mitral stenosis. So whenever you see a flow acceleration, then but you don't see any pathology on the mitral valve, be aware of the supramitral membrane. So Siling, what is the difference between supramitral membrane and co-triatriatum?
No.
Sarah, the difference between supramitral membrane and co-triatriatum?
Level of the membrane, right? Below the pulmonary vein, right? Insertion.
Yeah. It's not below the pulmonary vein, it's below what? Some other structure. Okay, Precious?
I can't remember.
Jeremy, what's the difference between supramitral membrane and co-triatriatum sinister?
Not sure, boss.
Is still around or not? Okay. So the difference between the two is at the level, okay? So supramitral membrane is below the left atrial appendage and co-triatriatum is above the left atrial appendage. Okay, so I show you here. So this is the patient, right? You see something that is surrounding, okay, this one, surrounding this thing. So this is a supramitral membrane on 3D view. So that is supramitral membrane there on the top there. So you can see here, yeah. So this is a supramitral membrane. You see that? When you do surgery, that is supramitral membrane. And where is it? Okay, so this is the difference. So co-triatriatum, the membrane is above the left atrial appendage. All right. Supramitral membrane, the level is below left atrial appendage. There. So that is supramitral membrane. This is the co-triatriatum. Is it clear? Siling, you understand or not?
Yes.
If you have supramitral membrane, the membrane is below the LA appendage. If you have co-triatriatum, it is above the left atrial appendage. Understand?
Okay.
Right. Saravanan, okay.
Yes.
And how do we tell from echo then?
Just now, I showed you just now. Just now, you see the band just below the mitral valve. So that must be supramitral membrane. Okay, co-triatriatum is above the left atrial appendage. It's at the middle usually of the left atrial cavity, not just below the mitral valve. Okay, so Precious, do you know how co-triatriatum happen?
Uh, during the embryology.
What happened during embryology? Okay, Saravana?
For
Remember the separation.
Jeremy? Okay, so I wanted to teach you today so that you will remember forever. This is just embryology, okay? So you all heard about partial anomalous pulmonary venous connection or not? Okay, you also heard about total anomalous pulmonary venous connection, right? So partial anomalous is, for example, in patient with sinus venosus ASD, when the right pulmonary vein go to the superior vena cava rather than go into the left atrium. So that is partial anomalous. So what happened is that during the embryological development, all the pulmonary vein actually go into a chamber that is called common pulmonary vein. So this common pulmonary vein should go and merge with the left atrium. It should go and merge with the left atrium. Now, if all the common pulmonary vein does not merge with the left atrium, this is called total anomalous pulmonary venous connection. Okay. If some of the pulmonary vein merge with the left atrium, that some of the pulmonary vein does not merge with the left atrium, that is called partial anomalous pulmonary venous connection. However, there is a situation when all the pulmonary vein, so all the pulmonary vein into the common pulmonary vein is able to merge inside the left atrium. But even though they merge inside the left atrium, their membrane is still not fully dissolved. Okay, so there is still partition between the common pulmonary vein and the left atrium. So that is co-triatriatum. So this is supposed to be a chamber of common pulmonary vein. All right, it's supposed to go and combine with everything. However, this membrane here doesn't fully incorporate it, so you still have the membrane there. So that is co-triatriatum. Is that clear?
Yeah.
Okay, Celine, clear or not?
Yeah.
Okay,
Yes.
Jeremy, is that clear? Jeremy?
Can.
Okay, so that is co-triatriatum. So, Saravanan, what is the difference between co-atriatum sinister and co-triatriatum dexter? What is the difference between dexter and sinister?
I don't know. I tell her.
Celine? Jeremy, what is the difference between Sinister and Dexter? What is the movie
Fail the
series?
exam, boss.
Yes.
I don't know.
All right. What about you, Precious? The difference between Sinister and Dexter?
a right atrium and the left atrium.
Okay, which one is right atrium? Which one is left atrium?
A dexter in the right atrium.
Okay. Okay, so Precious is correct. Very good. So the one on the left is Sinister. Okay, Sinister now because it is dangerous. If they say you have a stenosis, it is dangerous. Okay. Now the one on the right side is Dexter. It is benign. Obviously, the way the right side form is different from the left side. The left side is because of incomplete cooperation of the common pulmonary vein. The right side is just because it is a big inferior vena cava, okay, that goes across the right atrium. So that is the cause of co-atriatum dexter on the right side. That is a benign condition. That is just your eustachian valve, sorry, not EIVC, your eustachian valve, that separate the right atrium into two chambers, okay? So sinister is on the left side, dexter on the right side. Sinister is embryologically different from dexter. Is it clear? All quiet, ni?
I don't understand. Right side, left side meaning where is it? Like
So
on the
let's say you have left side membrane like this, that is sinister. That is because of you have a membrane there from the incomplete fusion of the common pulmonary vein with the left atrium. The right side, you will see a garisan there. Okay. Now the garisan there is not
Okay.
because of the membrane. It's just because that is just the eustachian valve. That is big. That seems like as if it is separating the right atrium into two chambers, but it's actually not.
Okay. So
See?
co-triatrium can happen in both right and left.
Yes, both right and left. Okay, but the right one is really is not for me. It is nothing. Not supposed to give it the same name because it is different embryologically. But the left side danger is sinister, right? In English, sinister is danger. So that's why the left side is sinister, and the right side is dexter. Okay, clear?
Yeah.
Sarah, okay?
Yep.
All right.
But sometimes they say clot can happen and all that, right?
Yes, correct. That's true.
Do we anticoagulate them?
No, we don't anticoagulate them.
Yeah.
All right. Okay, this is easy. I give Precious. This number 13. What's your answer?
Above the left atrial appendage.
Okay, so what is the diagnosis?
Above. So it's no, this is co-triatriatum sinister.
Co-triatriatum sinister. Okay, so Celine, what is this? Sinister or Dexter?
On the left side, so it's on the left. Left is sinister.
Okay, very good. So this is co-triatriatum sinister. So Celine, you asked me how they look like. This is how they look like. The co-triatriatum. Okay, this is co-triatriatum sinister. All right, we will look at apical four-chamber view, terbalik one. So this is LV, RV, LA, RA. That is the membrane. That's the membrane there. Okay. Right. And even this one is from, you see, I just wanted to show you this one. You know why? Because I wanted to show you that the membrane is actually above the left atrial appendage. Okay. So this is the left atrial appendage there. All right. So that is the membrane. So that's above the left atrial appendage. So this is. All right, so that's left atrial. Okay, this is left atrial appendage. One more time, okay. So this is the left atrial appendage. This is your membrane. So it's above the left atrial appendage. So this is co-triatriatum sinister. All right, so this is case number 14. So this is the right atrium. That is the right ventricle. Okay. So what do you see here, Precious?
Right atrium and right ventricle.
Right atrium, right ventricle.
Yeah, again, a color flow display.
So what is what the color flow show? So this is right atrium, right ventricle. So what is that?
So PR.
Yeah, so the patient got tricuspid regurgitation. Very good. Okay, so let's see another picture. All right, now, okay, do you see anything new or just tricuspid regurgitation? That's the same one, but we zoom.
There's another one.
Okay, what? Okay, so there's another one. So this one, right? That one, right? The one that I show here, right?
Yeah.
Correct or not? Okay. So, right. So there is another flow inside, seemingly coming from the inside the right ventricle. So you will have one tricuspid regurgitation flow and another flow that is continuous inside the right ventricle. Another flow that is continuous inside the right ventricle. Okay. So this is the tricuspid regurgitation. Okay. This is tricuspid regurgitation velocity. So the peak gradient is 20 millimeter mercury. All right. So this is the flow when we put a Doppler at the other flow. So the flow that is the second picture. So this is the flow pattern. Okay, that's the flow pattern inside the RV, the flow inside the right ventricle. Okay, so that's the flow. All right. And after that, when you do short axis view, this is the short axis view. Okay, when you do the short axis view, this is the short axis view. Okay, so what is your diagnosis of that abnormal flow?
Draining to the RV.
Sorry, Precious?
RCSOV draining to the RV.
Okay, you think that sinus of Valsalva from where?
To the RV.
From where to the RV?
From aorta to the RV.
From which cast? Can you got sinus of Valsalva? It should be from the right cast. So the right sinus of Valsalva should be somewhere there. So from the right. Okay. Ceiling, Saravana, anything you want to answer differently, Jeremy?
Is this windsocks appearance?
Yeah.
What windsock appearance? Not windsock appearance.
No.
From the LCC.
All right, very good. It is from LCC. Okay. So what is it that I'm measuring there?
The mouth of it.
Okay, what is it I'm measuring there? So you're thinking that this is actually a windsock appearance, right? But windsock, they shouldn't be continuous. You see this one, there is no break. There is just go away somewhere there. So there is not windsock. So this is something going there. This is just a left coronary artery. So what happens?
Windsocks, it should be.
If let's say you have a windsock, there should be an ending, right? Ceiling ending going to a certain place. There is no ending here. This is just a
Oh, okay.
It's going
Continuous.
there. Continuous. Okay, so what is this? What is this?
Fistula.
Fistula.
So this is what vessel is this?
Left main.
So this is a left main. Kalau right is going to be here. Right is going to be between the right coronary and the non-coronary cast. They're going to be right somewhere there. So this is the left. The left coronary artery is dilated. So what is your answer now? So you have a left coronary artery that is dilated. You have continuous flow inside the right ventricle. So what is the most likely diagnosis?
Fistula.
PDA.
Fistula, very good. So this is a fistula from left coronary artery into the right ventricle. Okay, is it fair? So whenever you see a continuous flow, what is your differential diagnosis? Ceiling.
PDA.
Okay, PDA sama.
Fistula.
Fistula sama.
Mixture of valve.
Okay, mixture of valve. The one that pressure is sinus of valve rupture. Okay,
Yeah.
one more. Saravanan, one more, last one.
VSD.
So whenever you have systemic to pulmonary shunt, okay, BT shunt, port shunt, or all shunt, because the shunt is between the artery and the pulmonary artery. So that all are the cause of continuous murmur. So this is an example of fistula. So I just wanted to give you a clue. So whenever you see echocardiogram and you see a continuous flow, like out of nowhere, you see inside the RV lah, inside the RA lah, think about fistula. Okay, that is quite common. So the diagnosis already know that is coronary artery fistula. Okay, so looking at the RV inflow, that is obviously RJ. However, there is another continuous flow in the RV. What is this? So there is a dilated coronary artery plus continuous flow is coronary artery fistula. Okay, the Doppler can also be similar to PDA Doppler. All right. So look at this case. Okay. Now I just wanted to tell you that this is the pulmonary valve there. Okay, that is the main pulmonary artery. So that's the pulmonary valve. That is the main pulmonary artery. So just look at this picture here. Okay, this is our next patient. So look at this picture here. Okay. All right. Now look this. So that's the pulmonary valve. Look at another picture. Okay, I play. Oh, guys, it's stuck again. Just remember, we almost finished this set of case. So I just restart the program. Just give me a moment. Right. Share screen. All right. I'll show you again. It is color flow. Oh, always stuck here lah. Sorry guys. What happened? Okay, just go down there. Okay. All right, can you see at least the slideshow? Okay, so I just play here. All right. So can you see that? Okay, this has happened. So you can see this is a vessel going to the main pulmonary artery. So there's a vessel going into the pulmonary artery. Okay, so vessel going into the pulmonary artery. So this is the first one. So that's the pulmonary valve there. So you have a pulmonary valve. So there's a vessel there that coming out from the main pulmonary artery. Okay, and then after that here, so you can see that there is a red flow inside that vessel going to the pulmonary artery. So there's red flow there. All right. Now, okay, retrograde flow into the pulmonary artery. Okay, there's retrograde flow into the pulmonary artery. So above is echo of an infant with dilated left ventricle, and ECG shows widespread anterior ischemia. What is your diagnosis? So what is your diagnosis, do you think? Okay. So that is the pulmonary. That is a vessel here, and the vessel here have flow towards the pulmonary artery bag.
Al Kappa.
Very good. Okay, this is an example of Al Kappa. Silik, have you heard of Al Kappa before?
No.
So, Al Kappa is anomalous left coronary artery that come from pulmonary artery. Yeah. Anomalous left coronary artery that come from pulmonary artery. That is Al Kappa. So in this patient, anomalous left coronary artery that come from pulmonary artery. So that is Al Kappa. So basically, in Al Kappa, what will happen is this. Okay. So this is your pulmonary artery. This is your pulmonary artery there. That's your pulmonary artery. Okay. So what happened is you have a vessel. The LAD that's supposed to come from the aorta actually come from the pulmonary artery. So that is the LAD there. Alright. So this is the LAD that is supposed to supply the left ventricle. But obviously pulmonary artery doesn't supply blood to the LAD. So you have RCA, and usually the RCA, the right coronary artery, is dilated. The RCA is dilated. So the RCA is usually dilated like that. Okay, the RCA is dilated. Okay. Now the RCA supply collateral to the LAD. So the RCA will supply collateral to the LAD. Okay. So what happens is the blood flow into the aorta, into the RCA, all right, and then they will flow retrograde, naik back LAD into the pulmonary artery. Okay, so basically the left ventricle is supplied by retrograde from the right coronary artery. So that's why here what you see is the retrograde filling of the pulmonary from the left anterior descending artery. Okay, so this is Al Kappa. So the way they present is at infancy with widespread ischemia of the left ventricle. So the way to correct this usually is the surgeon will just take the left anterior descending artery from the pulmonary artery, take it up and connect back to the aortic root. Okay, so that is Al Kappa. Is that clear? Jeremy, is that clear? Sometimes, yes. If let's say you have a good collateral, sometimes you can survive into a ductwork. Okay, meaning that most of the left ventricle is supplied by the right ventricle. It does happen, but rare. Okay, this is one. There's another case that is more rare rather than Al Kappa. It's atretic left main. So there is no left main. You said we got LAD and SERP, but you don't see it supplied from the left main. It actually supplied from the RCA. So there's another variant. So, but the most common one is Al Kappa. Anomalous left coronary artery from pulmonary artery. They also R Kappa. Anomalous right coronary artery from pulmonary artery, but that is rare. So, Siling, is it clear, Siling, Sravana?
Yes, yes.
Jeremy, is it clear?
Okay.
Have you ever seen Al Kappa before, Jeremy?
No.
Okay, this is how Al Kappa look like. Okay. So this is Al Kappa. All right. So, okay. So look at this. This is an apical four-chamber view. Right. So that is a left ventricle, right ventricle, left atrium, and right atrium. Precious, the diagnosis.
The RV and ASD.
Okay, there is a hole there. What type of ASD are we dealing with?
Primum.
Okay, this is primum ASD. Very good. All right. Okay, so that's primum ASD. Okay. Siling, what am I showing here?
Is this short axis view?
Short axis view of which structure? What is this? What am I trying to show in here?
Is it?
So that is the mitral valve, okay? That's the mitral valve. Okay, what's happening to the mitral valve, Siling? So that is a cleft mitral valve, okay? That is cleft mitral valve. So whenever you see an ASD primer, think about cleft mitral valve leaflet. So this patient have a cleft mitral valve leaflet. So why do patient with ASD primum have cleft mitral valve, Sravana?
What do you call that?
Okay, so this is another patient. So this is not same patient. This is another patient that have double orifice. So left-sided orifice and right-sided orifice. So this is actually a complication that can happen in patient with ASD primum. So they can have cleft mitral valve leaflet. Okay, I will show you what is the reason. So this is actually primum ASD. Okay, so primum ASD is part of the spectrum of AV canal defect. The other being complete transitional AVSD and inlet PSD. So because of the bridging leaflet, the left AV valve now consists of 3 leaflets, which is seen as cleft. So some people with primum ASD can also have double orifice mitral valve leaflet. Okay, so I just wanted to show you a primum ASD. So you remember, right? I told you that the primum ASD is actually a spectrum of AV canal defect. Do you all remember that?
Yeah.
So you remember or not? So you have a primum ASD is like this. Okay, you have a primum ASD like this, right? So you just have primum ASD like this. So you have just one hole here. Okay, so this is one primum ASD. Okay, this is then another one. You also can have primum ASD like this. Okay, so when you like this, so when you have like that, you also have hole here. All right. So this is primum ASD. Okay. Now this is what we call either a transitional or complete. Let's say if it is a transitional AVSD, this hole is small. So that is a restrictive VSD. If this is a complete AVSD, this hole is big. Okay, if the complete AVSD, the hole is big. Now, what happens in patient, either you are primum or you are complete or transitional AVSD. So what happens is your AV valve is abnormal. Okay. Now, your AV valve is abnormal. I will show you the structure of the AV valve a bit later. Okay, so just remember that this is the primum. So this can be transitional or complete AVSD. Okay. Now, the leaflet can either be common or they can bridge across that middle of the leaflet. I will show you a little bit later. Okay. Now, if you look at this primum ASD here, you can see that that is the primum ASD. The border of the primum ASD is actually formed by the atrial and the ventricle tissue. Right? The bottom primum of the primum ASD is formed of the atrial and the ventricle tissue. Only secundum ASD has pure atrial tissue around it. All the other ASD doesn't have, including primum. Okay, so this is the endocardial fusion. So at the primum ASD. That's the fossa ovalis there. Okay, the fossa ovalis, that is the membrane primum. Okay, so whenever you see the thin wall, that is the membrane primum. So that is the membrane secundum surrounding the fossa ovalis. All right. One of the complications of having primum or ASD or complete AV canal is what happens is that you can have what they call a left ventricular outflow tract obstruction. So the reason you can have left ventricular outflow tract obstruction in patients with AV canal defect is they can have abnormal chordae tendineae. So you know that on the left ventricle, the chordae tendineae should attach to the papillary muscle. But in patients with AV canal defect, sometimes the chordae can attach to the septum. So this can cause LV outflow obstruction. The second reason patient with AV canal can have outflow obstruction is this. Okay, so what happens is the aorta is actually unwedged from the mitral and tricuspid valve. So because the aorta is unwedged, the distance between the inflow and outflow become longer. So that's another reason of having left ventricular outflow tract obstruction. So let me summarize again. Okay, I know it's confusing. So this AV canal defect, it is a spectrum. So you can either have ASD primum or you can have transitional or complete AVSD. Okay. Now, all of these can have a common complication. What are their common complications? Number one, they can have cleft mitral valve. Now, the cleft mitral valve is not because there is a cleft. That is because the intrinsic abnormality of the valve itself that I want to show you later. The other complication that all these AV canal defect people can have is left ventricular outflow tract obstruction because the chordae tendineae is abnormally inserted into the interventricular septum and the aortic valve is enriched from the mitral and tricuspid valve. Okay. This is what I wanted to show you. Okay, so this is someone with AV canal defect. So what happened is that they have this common AV valve here. So they have the superior bridging leaflet, inferior bridging leaflet, left mural leaflet, the right side. They have right anterior leaflet and right mural leaflet. Okay. Now in ASD primum, they will have a bridge across this one. So you have a bridge here. So you will have something like this. So you have something like a bridge around here, okay, that separate the valve into the right-sided AV valve and the left-sided AV valve. Now, even though you have a bridge here, as you can see, this middle part here is naturally separated. It is naturally separated. So this is the cleft that we see in patient with ASD primum, okay. In patient with complete AVSD, there is no bridge. So you have a common AV valve like this, okay? So the AV valve is called like this, right? If you have a leaflet in ASD primum, you have 3 leaflet on the left side and you have 4 leaflet on the right side, okay, in ASD primum. So I hope this is clear. I mean, is that at least a little bit clear to you all? I don't know whether you are still with me or not. Right?
Yes.
And also another thing that you can see is the aortic valve normally should be in between the mitral and the tricuspid valve. So in every canal defect, the aortic valve is actually unwedged from the mitral and the tricuspid valve. So that's why we have risk of having left ventricular outflow tract obstruction. Okay, I hope you understand that. Okay, almost finished. Okay, this is number 17. Okay, this is transesophageal echocardiogram. All right, so this is actually your ascending aorta. Okay, this is some structure here. What is that structure, Saravana?
This one,
This thing here, this thing that look like a teardrop. So if you go to upper esophageal view of your TEE, you will see this ascending aorta, and also you see this thing here. What is that? Precious?
Is it a false lumen?
No?
Yeah.
What is that, Jeremy?
Not what you call it? This some dissection or some?
Oh, this is superior vena cava. Okay, that is superior vena cava. Okay, so one thing that I wanted to show you for those who develop TEE, so this is the superior vena cava in this view should be round. This is not round. It look like a teardrop. Look like a teardrop. So whenever you see something that look like a teardrop here, be suspicious of anomalous drainage of right upper pulmonary vein. Okay, in this patient, so this is the SVC, but this is actually the anomalous drainage of the right upper pulmonary vein into the superior vena cava. So for example, if you see someone with sinus venosus ASD, you take your probe up into the upper esophageal view, try to find the SVC. The SVC should be round. If you see a teardrop SVC like this, be suspicious of anomalous right upper pulmonary vein draining to that superior vena cava. You see here, this flow here. So red flow is the root flow towards the probe. You can see that there is red flow going into the SVC. You see that? Red flow going into the SVC. So this is flow from the right upper pulmonary vein into the SVC. So remember, find this in patient with sinus venosus ASD. Whenever you want to see whether the pulmonary vein is anomalous or not, look at upper esophageal view. If you see a teardrop looking SVC, so this is anomalous right upper pulmonary vein into the superior vena cava. So it is not bifurcation of main pulmonary artery, it is not Scimitar syndrome. Do you know what is Scimitar syndrome?
Drainage of a pulmonary vein to the
Right. Okay.
the IVC, right?
Very good. Into the IVC, correct. Correct. C, anomalous pulmonary vein entering SVC. D, left pulmonary vein to vertical vein connection. So the answer is anomalous pulmonary vein entering the superior vena cava. Okay. So now I wanted to talk to you all a little bit about anomalous pulmonary vein drainage. So you know, during the embryological development, okay, what happened is that you have something called the common pulmonary vein. So this is called common pulmonary vein. Okay. Now you have your right upper, right lower, left upper, and left lower draining on the common pulmonary vein. Okay. Now this common pulmonary vein will then go and merge into the left atrium. Okay, all right, merge into the left atrium. So Saravanan, if this common pulmonary vein is able to go into the left atrium, but is unable to incorporate the whole of its membrane, what is your diagnosis?
Total, is it?
No, it can go into the left atrium. So it is able to go to the left atrium. The only thing is the membrane is not fully incorporated into the left atrium.
This is co-triatum sinister.
Yes, co-triatriatum sinister. Very good. All right, co-triatriatum sinister. Okay, ceiling. Let's say the whole common pulmonary vein cannot be merging with the left atrium. What is your diagnosis?
The whole, not the whole thing merged with the LA.
So this
Partial.
doesn't, not partial, the whole thing didn't go in.
Total.
Yes, that is a total anomalous pulmonary venous connection. Will this kind of patient come and see us or not, Silek? No, because how can you survive with total anomalous pulmonary venous connection without any surgery, right? Everything doesn't go into the left atrium, so you cannot do that. So that is what we call TAPVC, total anomalous pulmonary venous connection. All right. Now, what is Jeremy? The left part. So the left part able to go into the left atrium. Okay, but the right part go into the SVC. What is that? So that is partial. Yes. So that is partial anomalous pulmonary vein connection going to the superior vena cava. All right. So that of course can be variable. So sometimes this can go to SVC. Sometimes this rather than go to SVC, it can go to IVC. Now, if this go to IVC, what does it call? That is called scimitar syndrome. So why does it call scimitar syndrome? The vessel, let's say you do a chest X-ray, the vessel that connect this pulmonary vein into the IVC, okay, look like this. Okay, look like a scimitar, the pedang of the sword of Turkish sword. Okay, that is what we call scimitar syndrome. All right. So that is one type. Some other type is the left vein sometimes can connect to the vertical vein and go to the SVC. Right? So there is many variation. But the three commonest variation of partial anomalous pulmonary venous connection is right pulmonary vein to the SVC, that's one. Number two is right pulmonary vein to the IVC, scimitar syndrome. And lastly, it is left pulmonary vein to the vertical vein and then to the SVC. Is that clear? Ceiling?
Vertical vein too? What is vertical vein?
Vertical vein is just a vein that is something that is congenital that hasn't disappeared. You and me, if you don't have PAPVC, we don't have vertical vein. Vertical vein is a vein that is connected to the brachiocephalic vein. Okay, so that is the partial anomalous pulmonary venous connection. All right. So this is another example. Okay, I just wanted to show you. Okay. Now you have, this is actually superior vena cava. So blue. So this is a transducer. This is blue. Blue is coming towards us. So this is the superior vena cava. All right. Now there is actually, however, abnormal blood flow going upwards. There's abnormal blood flow going upward rate. Now there shouldn't be, in normal people like you and me, there shouldn't be a normal flow going up. All right. So what you think is that this that vessel, Saravana? We just talk about it.
This is the pulmonary vein.
No, the one that I told you, vertical vein. This is the vertical vein. Okay. So this is vertical vein. So what is vertical vein? Vertical vein is like this. Okay. I'll just show you again. Okay. So now this is your heart, right? So this is your heart. Okay, that's your heart there. Okay, that's your heart. Okay. Now you have SVC coming there. Okay. So this is normal. So you have SVC. All right. Now you have a brachiocephalic vein that comes from the left side. Okay, the brachiocephalic vein going to the SVC. So the right upper pulmonary vein is normal. So the right go into the left atrium. So that's the right. Now the left upper pulmonary vein is abnormal. So it doesn't go into the left atrium. So what happened is, okay, rather than the right SVC, you also have another one here that haven't yet disappear. In normal people, it's disappear. This left vein in normal people is disappear. But in people with partial anomalous of the left vein, it doesn't disappear. So this anomalous vein connected to this vertical vein. So the vertical vein go to the brachiocephalic and go back to the SVC there. Okay, so this is the vertical vein. Okay, normal people don't have it. So this is what we see here. Okay, so whenever we see a vertical vein, we are suspicious of anomalous left upper pulmonary vein go into the vertical vein, into the brachiocephalic vein, into the superior vena cava. Is that clear?
This is what view is this again?
This is suprasternal view.
Suprasternal view.
Right. So if you do here, okay. So this is actually, so what is the diagnosis? So whenever you see that, there's only one diagnosis. So in suprasternal view, there is no other chamber that show blood flow upwards like that. So when you see that, there is actually an abdominalist left pulmonary vein that going to the vertical vein. So even if you still feel complicated, I hope you already know the embryological basis of partial pulmonary vein drainage and total anomalous pulmonary vein drainage. Are you at least clear about that? Really?
Yeah, I think so.
Okay, just 5 seconds. Okay, so during embryological, okay.
Sorry, I got one question. If the left pulmonary vein which connect to the vertical veins, it is also called PAPVR lah. I mean the partial.
Yes, correct. It's also PAPVR, correct. Okay, it's all PAPVC. Okay, so total is when the whole of the pulmonary vein don't go into the left atrium. Partial is when some of the pulmonary vein go into the left atrium, but some of the pulmonary vein goes to the other place. So the other place that is go, it can be SVC in patient with sinus venosus ASD, can be IVC in patient with scimitar syndrome, can be vertical vein for left pulmonary vein. Right? All right, so this is okay. Even a better gambar. I don't know why I do that gambar and stuff. So this example. So this is the left atrium. The right pulmonary vein is okay, going to the left atrium, but the left upper and the left lower, rather than going to the left atrium, it actually go to the vertical vein, and then go to the innominate, and then go to the SVC. So this is anomalous. So this is partial anomalous pulmonary venous connection of the left upper pulmonary vein. Okay, is that clear? All right. So the most common variant is the partial anomalous right pulmonary vein is the most common one. The left pulmonary venous anomaly, the one that I show you going to the vertical vein, is only 4% of the partial anomalous pulmonary venous connection. Okay, scimitar is even rarer, it's about 3%. All right. There is also other connections, such as connection to the coronary sinus, but this is very rare. So the most common is the right pulmonary vein to the SVC. Okay, second is the left, and last is the scimitar syndrome. So mixed PAPVC can also happen, but rare. All right. So this is actually, I just wanted to show you, this is example of scimitar syndrome. So this is a crack view. So this is a common pulmonary vein. That is a left upper pulmonary vein. That is a left lower pulmonary vein going into the common pulmonary vein. But as you can see in the crack view here, there is no right upper and there is no right lower pulmonary vein going to the common pulmonary vein. This is because the right upper and the right lower pulmonary vein is going into the IVC, okay, and become scimitar.
Boss, how do you get this view again? The crab view?
The crab view, if I'm not mistaken, is also from suprasternal view. You go from suprasternal view, but you have to rotate your probe. You can Google it. How to get a crab view in echo in Google. It is example of scimitar syndrome, right? So what about this one? What do you think is this one here? So this is almost finished here. This is parasternal long axis view. So you can see something there. All right, you also see something there, right? What do you think that? Okay, I want to one more time. Okay, there. Okay, so you see something here. Okay, you see something there that's not incorporated into the left atrium. Okay, this is not a membrane. Okay, so the left atrium looks okay, but there's something there that is not incorporated into the left atrium.
Is it the unroofed coronary sinus?
Not unroofed coronary sinus. CS will be here. Coronary sinus will be somewhere here. Okay, what? Remember, I teach you what should merge with the left atrium ceiling.
Pulmonary vein.
So common pulmonary vein should merge with the left atrium, right? So what do you think is this structure here? That does not merge with the left atrium. Okay, I show you at the back here. All right. What about this one? So what is this structure here? That does not merge with the left atrium. Right? Right? And if you see this structure actually goes straight away into the right atrium. So okay, I just teach you again, okay? Okay, we go to Saravanan now. I don't know whether I'm being a good teacher or not. Okay, Saravanan. Sarah,
Yes.
you can hear me, right? So remember I told you just now, one of the etiology of total anomalous pulmonary venous connection is when the common pulmonary vein cannot go into the left atrium, right?
Correct.
Okay, now I already give you the clue. Now I give you a clue here now. Okay, this is the left atrium. This is something that cannot be incorporated into the left atrium. What is this?
Common pulmonary vein.
Yes, so this is a common pulmonary vein that is separated from the left atrium. Okay, now that is so. So this is also the common pulmonary vein there that is separated from the left atrium. Okay, now when I put the color Doppler, okay, now I see this common pulmonary vein connected to my SVC and connected to my right atrium. So meaning that all four of my pulmonary vein connect to the SVC and going to the right atrium rather than going to the left atrium. So what is this? Is it a partial anomalous pulmonary venous connection or is this a total anomalous pulmonary venous connection?
Total.
So this is an example of total anomalous pulmonary venous connection. All of the common pulmonary vein doesn't go into the left atrium. So all the pulmonary vein in this situation go to the superior vena cava and go into the right atrium. So this is an example of total anomalous pulmonary venous connection. Right, your total anomalous pulmonary venous connection, it can either go supracardiac, so it can connect to the structure above the heart, such as superior vena cava. It can be infracardiac, it can connect to the vessel below the heart like IVC. It can also be intracardiac. In fact, that all your pulmonary vein can also go anomalously either into the right atrium or into the coronary sinus. Okay, so there is three types of total anomalous pulmonary venous connection. This is the supracardiac part of the total anomalous pulmonary connection. So what is the most likely diagnosis? So the diagnosis is the TAPVC that is going to the vertical vein, going to the SVC, that is then going to the right atrium. Okay, so this is total anomalous pulmonary venous connection example. All right, so I think that's all. So I think that is quite heavy. So what do you think, guys? What do you think? Any question?
I have one question.
Okay.
Just now you were saying about the mitral valve cleft, right?
Okay.
On